Great, thank you. So welcome to those who are here for what I know will be a wonderful talk. I'm privileged as co-director of NIMAC to be introducing Dr. Muin Khoury, who, as you can see, is the founding director of the Office of Genomics and Precision Health. He is a board certified medical geneticist, has received too many awards to cite, and has appointments in the Emory University Rollins School of Public Health and the Johns Hopkins University Bloomberg School of Public Health. He has written over 500 scientific publications, including 3 books, Fundamentals of Genetic Epidemiology, Genetics and Public Health in the 21st Century, Using Genetic Information to Improve Health and Prevent Disease, and Human Genetic Epidemiology. It's really an honor to have him return to our NIMAC meeting, whether virtual or in the past in person, to present our talk today, Health Equity in Genomics and Precision Medicine, a Public Health Imperative. Dr. Khoury has indicated he will take questions. You can put those in the chat, and Luba will be handling that part of the session. So Dr. Khoury, welcome and thank you.
Well, thank you so much, Joanne. I hope you can all hear me. I'm monitoring my chat box as we go through. It's sometimes funny when you're remote, you don't know who's there, but I've seen a few names that I recognized. And as Joanne said, I was a previous speaker at NIMAC a few years back. So some of you are coming back for an encore. What I would like to do today is cover 3 things, and hopefully we'll have some time for discussion. And those of you who heard me last time, you will see some degree of overlap. Wanted to try to describe the role of public health in this genomics business. And this is a good timing to do this because it's National Public Health Week. And people understand public health. People bring into public health whatever they want to bring in. So hopefully we'll have a good dialogue about that. Then I'll talk briefly about CDC priorities in this area over the last 2 decades. And then I want to close with what's been approached since the start of the pandemic and the rise of precision public health and new strategic planning effort for CDC. So we keep making progress in the field, genomics, and every year we write blogs about this. We have web pages, but I pay usually good attention to end of the year papers that come out of NHGRI by Terry Manolio and her group. They've been writing year in reviews for now 3 or 4 years. The point is that genomic medicine implementation is now occurring at a faster and more speed in different countries in the US. But there are many equity issues that need to be dealt with, and of course, evidentiary issues as we move forward. Some of you have seen my translation highway slide from before, but basically, we keep discovering stuff. Sequences, tests, this bench to bedside trajectory is very alive and well right now. What is the road less traveled really is what do you do with the information post bedside? How do we ensure that it can actually improve health of individuals and population? How do we put it in practice through implementation science? And then how do we monitor and make sure that we have the right regs, rules, regulations, capacity of the workforce, et cetera, to actually improve population health? So that cycle of T1 to T4, we barely pay attention to it in terms of funding, in terms of studies. And a case in point, a few years back, we did a couple of studies at the NIH where we found that about 2% or less of research funding and research studies, these are 2 separate papers in Genetics and Medicine by Megan Roberts, who's now at UNC, is in that T2 and beyond space. In other words, truly the road less traveled. 2% of research, 2% of funding is going into that last bit of translation to actually improve health. So this brings us into the role of public health. So what is public health? And who are the actors? CDC is just one actor. We're one of several federal agencies and HHS like FDA, HRSA, and others. But if you think about this old definition from the National Academy of Medicine, the IOM, that looked at whoever are the actors are interested in assuring the conditions for improving health of populations. So population health, public health, healthcare delivery systems, academia, communities, the media, we play a role. And when it comes to genomics, public health genomics is no exception. We are multiple partners here and players that are are concerned with effective and responsible use of genomics to improve population health. Now, the beauty of this diagram is also its weakness. In the US, public health is so distributed. There is no centralized, because of the nature of the federal, state, local jurisdictions, and then multiple healthcare systems, it's very difficult to assure the conditions for population health. So keep that in mind as we talk more about genomics. So over the last few years, especially during the pandemic, the concept, I'm using genomic medicine and precision medicine interchangeably, although there may be some differences here. This equity agenda has been rising to the forefront. And the more I read about it, the more I'm thinking, wait a minute, this is all about T1. This is all about genetic research. It's all about enhancing population diversity in genetic databases. Yes, we need that, but we're not going to solve the health equity issues in genetics and medicine in general and as a society with just T1 research, if you know what I mean. So this reminds me of Wiley Burke's paper from a few years back, in which they talk in this paper about health disparities in genomics. And the quotes on the right-hand side are very telling, because sometimes we confuse healthcare inequities and disparities with health disparities. And this is what we do again and again. We're not going to solve the problems only with T1 research. We need to cover the whole continuum. And in the case of genomics, what happens is that health equity issues compound themselves as we move down from discovery to implementation. So if you have databases like GWAS that are primarily based on Northern European populations that are not inclusive, that's what these papers were talking about, we are going to lead to discoveries that may not be interpretable or maybe more difficult to interpret in practice. So that disparity carries to the evaluation component, the T2 component. This is just one example from hypertrophic cardiomyopathy, a paper published a couple of years back that shows that among underrepresented minorities, the proportion of genetic results that are inconclusive, that cannot be actionable, increases. Why? Because of that cascading effect of T1 disparities. If you don't do the right research on the right populations, you won't be able to interpret the test that would be used in practice. And last but not least, the implementation disparities is sort of what concerns me as CDC a lot, and a few other federal agencies and public health in general, is that, okay, we've done the research, we've discovered, we have valid genetic tests, but the uptake, the referring people to the right services and assuring that these services are done for the benefit of people, families, and populations is lagging behind. So in the case of genomics, we have health equity issues throughout the translational continuum. So I want to switch gears to what CDC is doing in that space. And we've been at this now this is our 25th year, where the Office of Public Health Genomics, and now changed to Genomics and Precision Public Health. I'll tell you why later on and during the discussion. We have a very simple mandate, not much money, not much resources, but our office tries to do three things: essentially identify, inform, and integrate. So we try to work to identify evidence-based applications that can actually save lives, prevent disease, or treat diseases. And then we work with healthcare, public health programs, and the general public to inform them and communicate about these issues. So we have a vibrant communication issue. But then most importantly is those few and increasing number of applications that are ready for prime time, we work tirelessly with programs, both at CDC and states, to actually integrate these discoveries. And I'll talk about a couple of examples in cancer and heart disease and birth defects that show that we need to take the discoveries all the way around the circle to improve population health. And that's sort of the mission of our office. So you can't have a talk about public health genomics without newborn screening. Although I'll just have it in one slide, newborn screening is a sort of a recurring theme, probably the only large public health genetics program in the US in all 50 states. All other genomic applications across the lifespans are much more spotty. So you know this more than I do. There are, every state has a newborn screening program. It's becoming more and more, has increased in number and scope of conditions that are covered, not just genetic, but other things. And now genetic sequencing is knocking on the door. So I'm going to keep that knock on the door. If people want to discuss what that means, I'm happy to discuss it in the Q&A section. But basically, sequencing is already a fact of life for a few sort of genes that are in the newborn screening panel, but not as a first-tier test for most conditions. So keep that in mind. Now, more generally, if you take a life's course approach to genetics and genomics, we scan the horizon every day. We look at professional organizations' guidelines, and we look at the epidemiological and clinical literature. For a while, we had our own evidence-based synthesis group, the EGAP working group, which has been dismantled a few years back. But we apply rigorously this simple classification, tier 1, tier 2, tier 3. Some of you have heard this before. People talk about the CDC tier 1 applications. What this simply means is that this means that these applications are ready to be implemented. And if implemented, because they're supported by an evidentiary foundation and clinical guidelines, they can actually save lives. I mean, newborn screening is a quintessential tier 1 application. We'll talk more about a few more things. The reason we came up with a simple diagram is part of the CDC and other groups. When we were going around trying to sell genomics, people would tell us, look, tell us when things are ready. We go visit the diabetes division, the heart disease division. So now we go with them with a simple chart. This is tier 1, this is tier 2, this is tier 3. A lot of genomics is still in tier 3. I mean, the genome is wide, it's big. And, but many things are moving into that tier 2, especially pharmacogenomics and a few other things as well. This is not static. What today may be called tier 3, maybe tomorrow tier 2, and then tier 1 eventually. But we're making progress. So about a decade ago, can't believe this has been a decade, where we did the last round of strategic planning. And I'll tell you about the new round in a few minutes. We actually, with a lot of stakeholder consultation, came up with a simple emphasis on just 3 conditions: 2 cancers and heart disease due to familial hypercholesterolemia. This number of tier 1 applications has now increased. We have other things from the ACMG list, like hereditary hemochromatosis, hypertrophic cardiomyopathy, et cetera. But for the last 10 years, we focused our energies in using these as exemplar and identify, inform, and integrate. And we've been moderately successful, even with not much funding, to try to integrate these conditions into cancer and heart disease programs, both at the federal level and the state level. Now, these are autosomal dominant conditions. Think about that for a minute. There are only 3 conditions, 10 genes total, but collectively, about 1% of the population have these conditions. And many people don't even have it. And there are recommendations for action. So keep that in mind. These are the actual recommendations on BRCA testing and counseling. The last one was done by the US Preventive Services Task Force in 2019, but actually this is the 3rd attempt at updating that recommendation, which started in 2005, if I'm not mistaken. EGAP, our own group on Lynch syndrome, and then from the UK and beyond, cascade testing. Cascade testing is a common sort of a common platform for all these three conditions and genetic disease in general. We'll come back to it in a few minutes. So if you're in public health, like I am, you go to the cancer division and they will say, why should we worry about 5% or 10% of a particular disease when we're trying to get people to do colonoscopies, people to do breast cancer screening after age 50? And I say to them, because these people are at exceptionally high risk and your recommendations don't apply to them. They have to start screening earlier. They have to be done more often. And they may require they may require surgery. They will require chemo prevention. And if approached the right way, you can save a lot of lives. I mean, think about the annual cases of just these two genetic syndromes in cancer. You know, it kind of even eclipses the number of babies that we identify in newborn screening programs every year, which is about 10,000 to 20,000 total. So we can do more for prevention if we expand our horizons and not just focus on whether or not these conditions are the minority of cases of these cancers. So as a result of intensive effort over the last few years, which is now embedded in the cancer genomics program at CDC, a few states like Michigan, in this case, have embedded genetics into their cancer programs. They have actively gone out to try to implement the task force recommendations, leading to more testing, more counseling. This data starts back in 2013, but this has continued to move forward. What is not seen here are racial, ethnic, and geographic disparities that continue to occur even today. So more generally, talking about the equity issues, this is our own analysis we've done a few years back based on administrative data, looking at the whole country and looking at BRCA testing over time and the difference between rural and metropolitan areas, rural urban areas in the US. Those numbers and those graphs continue to go up. We're about to do the next round of analyses, but the discrepancies are still there, which leads us to focus more on equity issues. Notice the bump in 2012 for both rural and urban areas. That corresponds to two data points. The first is the Affordable Care Act, in which now covers U.S. Preventive Services Task Force recommendations that are B and beyond, which includes the one on BRCA counseling and testing. And two, in 2012, the Supreme Court invalidated the Myriad Genetics patent, which has allowed the prospering of other cheaper genetic testing platforms for BRCA. So you can see here that legislation and policy do have an impact on public health. Switching over to familial hypercholesterolemia as a prototype tier 1 application, the bus you see here is sort of a public education campaign that the FH Foundation did a few years ago. I was driving one day in Atlanta, this is Marta, and I saw this bus ahead of me. And I thought, I can't miss on that chance. I need to take a picture of this bus. So FH is a condition, it's fairly common, 1 in 250 people have it. It's a disease, it's a genetic defect of LDL cholesterol. 3 or 4 genes account for the majority of the cases and leads to a very high LDL cholesterol. There are evidence-based recommendations, but most people with high LDL cholesterol are not diagnosed. Actually, most of them don't have FH, and the few that do are not being diagnosed. And then there are racial ethnic disparities. So there are definitely missed opportunities. This is our own analysis from NHANES, the population-based survey, which is representative. And there are 3 bars here: general population, people with high cholesterol, and people who we think have FH. Until recently, there was no ICD code for FH. This is a problem, but now since 2016, there is an ICD-10 code for FH specifically. And you can see here, just focus on this bar, only 50% of what we think is FH patients in the US are on statin. And 80% of them have used statins in the past at any one point. Only 20% or less are using high-intensity statins like PCSK9 inhibitors. These are people who, many of them require high-intensity statins. So we tried to summarize this paper in this visual abstract, which is on our website. And people with FH have an increased risk of premature heart disease. Many of them, most of them know they have high cholesterol, but the minority take statins in the population. So these are sort of points to consider for the general public and the healthcare providers. Now, switching over to cascade screening. This is the most complicated genetic issue that kind of sits between medicine, public health, and community concerns. This is from a paper we wrote with Josh Knowles back a few years back, talking about cascade screening and the challenges. And this pedigree, which is a fictitious pedigree that JAMA helped us put together, illustrates the complexity of cascade screening. So this is one pedigree. People live in different states, different geographic locations, different healthcare systems. So this proband here in Oregon, the recommendation is to cascade to first-degree relatives and then stop if you don't get an FH patient. But how are we going to cross boundaries between states, between different healthcare systems? Relatives are in Texas, in Virginia, in this case, and throughout the nation. This is the ultimate challenge. And with that, this is a visual abstract from this paper that talks about cascade screening here on the right-hand side. But since then, we've made more progress. Recently, our office sponsored both a webinar on public health genomics action for cascade screening, just using a few of these diseases as examples, but they actually do apply to other genetic disorders. And then we had a workshop, which was not open to the public. We're currently writing the recommendations that came out of this workshop, but we use this sort of complicated diagram, which was developed by Laura Senior from Northeastern in Massachusetts, about how the public health functions and the players and the periphery. You see those healthcare systems, professional organizations, public health, actually interface with these actions that could enhance cascading, managing quality, restructuring, planning, educating the public, educating providers, policy changes like HIPAA and other things. So, and then key measurements for outcomes. So this is a true implementation science framework that would allow, hopefully with some funding, to make progress in cascade screening for these and other genetic conditions. So I want to switch to other conditions, because sometimes when people listen to me, they think all we care about are 3 genetic diseases. And that's absolutely not true, because we follow the science and everything is on the table, including family history in general. Family history is the ultimate tool that we should all be using as a public health tool, because we all have it. We all have a family history of something. And most of us don't know how to collect our family history. By the way, the Surgeon General tool, which was developed 15 years ago by the National Human Genome Institute and our office, the Surgeon General tool, is now permanently on our website. There are multiple other tools that people are using in practice. So the challenge is how to integrate those tools in the healthcare sort of flow of activities, and then allowing people to collect family history on the side. Rare diseases, by all means, there are thousands of rare diseases, and the time is becoming right to have a genetic approach to rare diseases, as the number and the proportion of diagnosed babies, children, and adults with rare diseases is going up the more we apply genome sequencing platforms acutely in infants in the NICU, and also deserve a look from a whole genome perspective. Polygenic risk scores, I know people are excited about it. I still think it's a tier 3 application, and people may disagree with me, but there are a few areas in polygenic risk scores that may deserve a tier 2 label. But for the most part, especially because of the scores not being collected from the appropriate populations, will make their use in these other populations more problematic. Pharmacogenomics, then last but not least, population-based DNA screening. A few words about each one of these conditions. I like Heidi Rem's recent paper that expands the access, the diagnostic access to rare disease diagnosis through genomics. Obviously, there is plenty of research to be done, but by combining research with learning healthcare systems, we can provide service to patients, make a diagnosis, and occasionally make a treatment that would match that diagnosis. It's not happening universally yet, but with increasing frequency, it's happening. And this is our paper on public health approaches to rare diseases. And you all know the numbers, the end to the diagnostic odyssey. But think about the millions of people who can benefit from genomics if applied at a large scale from using genetics. As I mentioned earlier, pharmacogenomics is an upcoming field, but for the most part, although it's been implemented in some health systems for some conditions, but preemptive pharmacogenetic testing, meaning being present in the chart of people before they take a drug like statins or clopidogrel or what have you, is still an idea that hasn't materialized. But the most promising thing in my mind right now is thinking about genomics across the lifespan like a newborn screening proposition. We screen newborns to pick up rare conditions. As I gave you the example of 3 genetic diseases that affect mainly adults, where the screening needs to occur in young adults, we're already in the millions. And with the list of 73 or 75 genes now from ACMG, not all of them are tier 1. One can make the case that you could put together a population screening panel that needs to be explored, could be used, could be evaluated, and then if it works, be implemented in healthcare system. So these are 2 papers we've written discussing the idea for DNA-based population screening. So while I think we're not quite ready for routine implementation, but we're ready for more an in-depth look at the harms and the benefits of DNA population screening in adults using a reduced panel of genes, primarily derived from the ACMG list and the CDC Tier 1 list. So in the remaining time, I'm going to switch over to the COVID era, talk a little bit about the progression to precision public health and our recent strategic planning and new initiative. So over the last few years, we've seen this kind of transition from genomic medicine to precision medicine and now precision public health. In medicine, we use genomics and precision interchangeably, but in public health, we don't. Actually, there are many precision points in public health that are way beyond genomics. I'll give you some examples. But to tackle any problem, whether medicine and public health have always been partners. We're part of the actors that improve population health. And as medicine becomes more precise with tools of genomics and other things, public health is becoming more precise. So a few years back, I wrote this concept piece to try to evaluate how the public health functions of assessment, policy, and assurance can benefit for more precision approaches, including big data. So no need to focus on the complexity of this, this image, but it tells a story. We are inundated with data. We're inundated with things more than the genome, and we are figuring out how to use them. So if you are in public health and epidemiology like I am, the data that allows us to collect and assess health of the population is looked at by person, place, and time. Who is the person getting the disease, where, and when? And that's the underlying foundation of Public Health 101. We can now, using genetic tools and other tools, be able to find and tailor public health approaches to the right people in the right place at the right time. It's still an idea that needs to be explored. And there's been a couple of papers written about this. Khoury Arnold wrote an editorial in Nature not too long ago, but earlier I had collaborated with Sonia Rasmussen, geneticist from Florida, and also Carlos Del Rio, an infectious disease person, talking about precision public health as a tool in the COVID response. Because we use these tools for other things, including apps, including big data, including monitoring, artificial intelligence. And the main example of precision in public health to fight COVID has been and will continue to be is pathogen genomics, not the human genome, but tracking variants and relating variants to clinical picture, response to vaccines, designing vaccines are all part of the precision approaches. Because otherwise, if you can't measure the virus at the population level, you're flying dark, essentially, you're flying blind. So the tools of genomics are being applied as we go forward. But the issue with and also on the host side, as we all know, COVID is not universally affecting people the same way. Of course, there are underlying conditions and age that increase the severity of COVID, immune defects, and so on and so forth. But there is a large role to play in genetic factors. This data published last year from the COVID-19 Host Genetics Worldwide Initiative was essentially based on more than 50,000 cases from many, many countries and found multiple hits in the genome. It was a GWAS study. The question that I raised from a public health perspective, how can we use this information to tailor and develop more precise approaches to COVID control, prediction, and diagnosis? I don't think we have the answer yet, but people keep looking at the genome, the human genome, in addition to the viral genome as well. Now, what happened during the COVID pandemic, and it's not over by any means, is that it uncovered the health inequity issues, both in the morbidity and mortality from COVID and healthcare in general. And as a result of this, we were charged with developing a new strategic plan for CDC. I spent last year talking with many of you, including Joanne and others. I talked with NIMAC and practically all the 7 regional networks, multiple federal organizations, and tried to figure out what should we be doing. Remember, our last strategic plan was done in 2012, so it seemed like the right time to do it. Cut a long story short, at the end of the calendar year, we received some money to launch into a 5-year initiative, which is now we're just beginning. And we're using a health equity lens to look at the 10 essential public health services as they apply to genomics, human genomics in this case. And so people in public health know about assessment, policy development, and assurance. So there is nothing really new here, except that we're going to try to make a concentrated effort following the science, following the few leads that allow us to essentially make progress over the next 5 years. Because I don't know how many chances we'll get to make things right in this area. Now, we've written a paper which is now in press in Genetics and Medicine, which is the title of my talk. So unfortunately, I cannot share it with you yet because it was just accepted by the editor yesterday. So I just share with you the 3 part of the table of our vision and sort of the low-hanging fruits around assessment, policy development, and assurance. You don't need to read the text here, but we're going to try to make progress in both surveillance at the population level, doing applied and implementation research to figure out what works and what doesn't work in public health, and working with healthcare system. We're going to try to continue and work with professional organizations to try to do the evidence synthesis and the national and community-based guidelines that would allow that step that moves between T2 and T3. Because right now, people are trying to chase the latest genomic application, but once it reaches a certain critical mass of evidence, we switch gears and we say the switch is to green. And we want to try to accelerate that process in conjunction with professional organizations such as ACMG and SGC and others. And last but not least, trying to develop the capacity, which is both in genetics and the medical capacity, as well as building model community programs and the right tools and resources around a few applications that can actually make a difference over the next 5 years. So, so what we did at the end of the year, we developed this initiative that has 3 components. The first component is an assessment component, and we are drawing on the strength of the agency, which is the National Health Examination Nutrition Survey, which is the only population-based representative sample of the US. This has been going on for many years. We've used it in the past. It kind of got derailed during the pandemic. They're going to start again. And we're going to try to measure genes, probably GWAS and a few other genes as well, and family history in NHANES, both prospectively and retrospectively, going back over 20 years. The beauty of NHANES, it has already collected all the phenotypic risk factor biochemical measurements on people. And we're going to try to compare data from NHANES with data from all of us. All of us is much bigger than NHANES. It is inclusive, but not representative. So we have an interagency agreement with NIH All of Us program to try to do this crosswalk between NHANES and all of us. Number 2, we're going to ramp up evidence synthesis and capacity and training. We're going to put out a few positions for training at different parts of CDC and health departments in general. I think we need to build the next generation of leaders in this field. And last but not least, we want to support pilot projects. So late last year, we developed a process by which CDC programs and their partners applied to get some of this money for pilot projects. We received 23 applications. We couldn't fund most of them, but we funded 6. And these are the 6 that are described in detail on our website. Notice that they run the gamut from infectious disease to newborn screening to birth defects, as well as hemophilia in this case. There are 2 or 3 or 4 that will be funded in year 2 that would be around cascade screening and maybe around cancer and heart disease. So if you're interested in finding out what these projects are about, you're welcome to visit our website and take a look. So in order to allow some time for discussion, I wanted to kind of leave you with my overarching summary here, and forgive me for going too fast here. I could slow down and speak for 5 hours, but you don't have 5 hours. But the points I want you to take home are the following. Public health genomics as an interdisciplinary field between genomics and public health goes well beyond discovery research to cover the whole translation highway. That's the reason why the field exists. And health equity is our imperative. But in order to achieve health equity, like in other areas of medicine and health in general, we need this multi-level analysis and implementation science, because it's not enough to get to guidelines. Once you get to guidelines, you need to close the loop. You need to close that circuit. And public health in general has an important role to play across the lifespan in genetics, beyond what we all call traditional genetic services, which is the genetic services model. Because as genetic information gets integrated into healthcare in general, think pharmacogenomics, think cancer screening, think treatments in general, we're going to have to be a bit more holistic in trying to cover all the bases. And last but not least, this COVID pandemic, which is really has been a major disruption of health and public health in the US and around the world, has been an opportunity to address health equity issues in genomics and beyond. I don't think we should squander that opportunity. We should learn from that pandemic and see how we can do better moving forward in the next few years. So with that, I'm going to stop sharing and see if there are any questions for me.
So, so Dr. Khoury, Joanne, before she left, had two burning questions. Of course, she would have burning questions.
Always.
Her first question was, what do you see as the opportunities and challenges in our electronic medical record systems?
How much time do you have?
I knew she would ask you that question.
Well, let's put it this way. It's work in progress. It's work in progress. I think the more implementation is happening in electronic, I mean, it is the way of the future, obviously. We're not there yet. There's been focused investments from the federal government, from healthcare providers. We need interoperability. We need the data to be widely available and shared. So there are both ethical, legal, and scientific issues. But the more we use electronic health records, the more we learn that what we've been doing so far needs to change. So the few places where electronic health records have been integrated have made the most progress in showing and integrating genetics and other things in general. I mean, this goes well beyond genomics, but you cannot do genomics without electronic health records. So I may be avoiding answering the question directly because it's a multi-level question where multiple players have to play a role, and certainly the sharing of data is very important. And one area in electronic health records, which is near and dear to my heart, is this overlap between research and learning health systems. So what we call research now, biobanks, like Geisinger, different healthcare delivery systems that have biobanks that are being done for research purposes, are migrating using returning results and then adding data into the electronic health system. This is the only way where we can discover and implement at the same time. And that applies certainly to the rare disease field and pharmacogenomics, last but not least.
And Joanne also wanted to know, can we learn from other countries that have a universal health system?
Yes, we can. And the problem is, unless we change, let's take UK as an example. I mean, I'm not endorsing any of their activities, but they have started with the UK Biobank 2 decades ago, which is equivalent to the All of Us research program here. They've had the 100,000 genome project more than a decade ago because they were able to, through a unified approach, integrate what we're trying to do in the US, one health system at a time. Newborn screening is an exception, although it took time to harmonize because we have 50 states. Now we have a universal recommended panel. We have an advisory committee that essentially makes recommendation, and we have 50 states that do the implementation. We need processes like this for genomics across the lifespan, not just at the newborn screening point. So yes, we can learn from other countries, but unless our geopolitical healthcare environment changes, we're going to continue in this hybrid mosaic form of a public health system where you see all the players trying to hold hands at the periphery, with a little bit of tension among them. But, we all share the same purpose of improving the health of the population, no matter how we get to it.
And Alyssa actually has a question in the chat where she's asking that, as the NIMAC has grown into supporting programs for Puerto Rico and the Virgin Islands in 2020, we've that as we're collaborating with HRI, with HRSA funded organizations that are covering this area, we're noting that some of these public health programs and messages that are used in the continental states don't work or or not appropriate in those territories. Is there something that the CDC has encountered or actually thought about and can help us
Absolutely.
with that?
Absolutely. Puerto Rico, send me an email. We can talk. I mean, there's no problem talking. We've had multiple consultations and with different states. I haven't talked to Puerto Rico, at least recently. The one caveat I might say is because of the fragmentation of the federal government with different mandates. And I've talked to HRSA last year. I don't know if there are HRSA representatives here. Their mandate has been MCH and newborn screening. So whenever we try to take genetics across the lifespan, some of those mandates will have to be evolved, and it may be difficult. So you touch upon other programs like the cancer. I mean, there are cancer registries in every state. I don't know about Puerto Rico, but you may have your own cancer registry. So the cancer programs may have to pick up their work around hereditary cancers and now cancer genomics, et cetera, et cetera. There are heart disease programs, there are diabetes programs. So the genetic services model at the state level as primarily applied to the newborn screening MCH arena. Although in the past, there have been a few states that experimented with a genetics model across the lifespan, like Connecticut, Michigan, Washington states and others, Hawaii. So there is no one size fits all, but the bottom line is that funding is difficult to come by for these post-MCH issues. And as you see, the tier 1 applications are increasing in numbers, and therefore the opportunities to save lives are also increasing.
Are there any other questions from our group today? So I have a question about, you have the tier 1. I mean, what do you see as the most effective way of promoting that information to the primary care community?
Again, there is no one size fits all. Primary care community in different communities play a different role. They are inundated with other things, other genetics. My own daughter is a primary care provider. She lives in Seattle. Every time I talk to her about genetics, she says, well, it's not even on my radar screen because I'm busy. And, with COVID-19, that busyness and option with telehealth and so on has taken on a different framework. So we have to all be creative in approaching primary care. And it may have to be for a while disease specific. So we'll try it with FH, we'll try it with hereditary cancer, we'll try it with a few things. But if you inundate them with, a list of 7,000 genetic diseases, I'm sure they will revolt. So, but if you arm them with the right tools, for pedigrees, for this, and having to know at one point a referral should occur, that's sort of that sweet spot between primary care and specialty care. But for the most part, a lot of tier 1 genomic applications do not need a referral to a genetic service per se. I mean, think about FH. The cardiologists take care of familial hypercholesterolemia. There are very few genetic counselors who do cardiology genetics, whereas in cancer, the field has prospered. Genetic counseling in cancer has been more apropos. So we need to follow the data. We need to enhance the workforce, both at the primary care level and the specialty level. And I'd be delighted to speak with the professional organizations, which we are speaking with, and the various networks who are experimenting with different things, as we were told when we spoke with a few of them last year.
You also have a question from Andrea Durst in Pittsburgh. She thanks you for your update, and she says, I'm working as part of a state cancer genetics work group to implement goals around tier 1 conditions for a state with no funding for public health genetics across the lifespan. What do you feel is the one strategy that would be most impactful to try to work on better identifying people with hereditary cancer syndromes?
You just need one strategy, Andrea. Where are you?
I'm here.
How are you?
I'm good.
the policy change is the strategy that works the most. I mean, we can experiment with different pilot projects here, there, and everywhere, but at the end of the day, if Congress and the states do not act to change the status quo, it's a shame. I mean, I'm not telling you all what to do, but the funding for public health genomics is very limited. So in order to do things at the state, region, and different locales and different organizations, there has to be funding. We kind of know what to do. There is a scientific agenda, there is an educational agenda, but until you change the framework of genetics in these contexts, we're going to be limping along. Now, that's not to say, Andrea, that you cannot do things in your state with the cancer programs, because the cancer program at CDC is funding states. I don't think Pittsburgh is one of the funded states. So you can work with the funded states. I think they include Michigan, Oregon, Washington, maybe Utah, and also work with us and the cancer program at CDC. It's one of the more mature areas in public health genomics at CDC in order to make progress in what you're trying to do. So borrow from other locations, adapt. If you have educational materials, etc., launch pilot projects, collaborate with academia, universities. I mean, they can get NIH funding. And one of the things I've successfully, I can take some credit for, is over the last 10 years, I was able to move the NIH implementation science agenda, both at NCI and NHLBI, towards more implementation science in public health genomics. So there are funded projects that are leading to tools and approaches that work. And I would encourage you to check them out. And I'm happy to talk to you offline anytime.
Great, thank you so much. That's really helpful. We're an all volunteer group, so we tend to tackle one thing at a time.
So I just have two more items. I just wanted to sort of highlight this message from Iris, who is telling us, who is sharing from the U.S. Virgin Islands, that they have a tumor registry, but most patients get treatment on the mainland. So we miss some, and others are on 2 registries. And how can we modify this? And so clearly a systems issue that we are becoming aware of as we do our NIMAC work. And then Alyssa asks, what
can I just answer that quickly?
Go ahead.
One quickly. So one of the projects that did not get funded, but will be next year or the year after, is integrating hereditary cancers into the cancer registries. So the cancer division at CDC is ready to go. They have been trying to do that with a few states, and with a little bit of extra funding that we can provide next year, we might be able to extend the scope of that, because it requires a crosstalk between the registry at the state or regional level with where patients are diagnosed and where patients get the treatment. And until that crosswalk and crosstalk happens, then you cannot have that data at the central level. Why is that data important? Is because this is the place where you can figure out how many breast cancers have been due to BRCA mutations. Are their outcomes different? Are they getting the right interventions? Are they getting counseling? And data speaks. And then once you know what the data looks like in your state or your region, then you might be able to develop the right programs to address the deficiencies in that effort.
And Alyssa asks, what role do you think social media has in spreading the public health genomic message?
My favorite question. For those of you who follow me, I'm a social media person on Twitter, and I think social media has a great role to play. Unfortunately, and people remind me all the time, including my own staff, I speak at a very high level language. Even my wife told me this morning, I can't understand your tweet. What the hell are you trying to say here? So social media is very, very important. People pay attention to it. We need a more nimble approach to spread the right messages, like we're trying to spread the messages this week around National Public Health Week, which is celebrated across the nation, that yes, there is public health genomics here. Pay attention to it. I wrote a blog 10 years ago which we republished. It's called A Day in the Invisible Life of Public Health Genomics. It's a story. Go read it. It's, maybe for one time I spoke at a different level than a, post PhD type discussion, but I told the story 10 years ago. Social media is important and we need to capitalize on it.
Do we have any other questions from our group? We're coming to almost to the close of our session. Dr. Khoury, this has been a very interesting lecture and a lot of things to think about. And I guess those of us who are involved in social media have to add us to our, add you to our social media activities. So hopefully you get lots of new followers today.
Nice. Check out the blog. I think.
Yeah, I put it in there.
Anyway, thank you for having me. I really appreciate it. And hopefully next time we'll be in person where we can actually talk in person in the same room.
And I'm sure I speak for the NIMAC group. We're glad to be partners in whatever way we can as you try to promote this work. So thank you again.
Thank you.